medication. The Belize study to show anti-karyogenicity. Summary: a 24-month double-blind study of 510 6-year-old children used to determine the effect of xylitol in rehardening of dentin lesions in primary dentition. The method: randomly assign patients to 7 groups and provide xylitol, sorbitol, a xylitol-sorbitol mixture, and a control group. These were all chewing gums. Provide supervision for regular use through school teachers for 200 days, and provide instructions to the parents for use on non-school days, and evaluate the rehardening process of carious lesions. This chart here, you'll notice again that we're looking at DMFS increments. The no gum study had an increase of 5 surfaces. Sugar gum, total of almost 7 surface increase. The sorbitol gum, a little more than 3 surfaces. The xylitol, the X and the S stands for the xylitol-sorbitol combination gum, which shows very good, probably less than 1 surface increase. But the xylitol gum, only 100% sweetened, shows that you actually have a decrease in the number of surfaces. What's significant about this is that we're actually showing remineralization, or 2 surfaces that were etched and had cavities when the study began have now hardened, and you're seeing fewer decayed surfaces. It's also significant that with the xylitol-sorbitol gum that it's not as effective as xylitol. Now, we have a lot of gums on the market are claiming to have xylitol in them, but they also have a lot of other sweeteners in them, whether it be sorbitol, mannitol. To me, this study here will be indicative that those gums will not be as effective as 100% xylitol sweetened gum. The results of that study show that high xylitol content chewing gum usage can retard or arrest rampant dentin caries. Caries reduction: there was up to an 80% reduction in the caries incidence in the Belize children. Xylitol can significantly decrease the incidence of dental caries. Xylitol is only one part of a multi-intervention approach for the prevention of dental caries, along with fluoride, chlorhexidine, dental sealants, mechanical plaque removal, and regular professional care. With habitual xylitol use, there is a shift in the bacterial flora to a xylitol-tolerant population. This is a favorable change because xylitol-resistant bacteria tend to be harmless. Let's talk a little bit about the term xylitol-resistant. Many in the industry feel that the term xylitol-resistant means that eventually the bacteria will no longer respond to the effects of xylitol and dental decay will return to its normal amount. But xylitol resistant is actually a positive term. We group bacteria into high acid forming, moderate acid forming, and low acid forming. High acid forming bacteria, when they come in contact with xylitol, their cell wall becomes quite slick, and the property of increasing salivation removes these bacteria from the mouth. It removes them fast enough that they're not able to replenish themselves, and the colony slowly disappears. Moderate acid forming bacteria are removed a little bit differently with xylitol. They take the xylitol into their cellular structure and try to phosphorylate it or make it into an acid. They're unable to do this, and they will continue to try to phosphorylate this, sometimes long enough that they develop a futile cycle that ends up in cell death. These bacteria, it takes them 16 to 24 months to remove this strain of bacteria from the mouth. Now, what's left is your xylitol resistant, or your low to no acid forming bacteria. And we're not concerned about those bacteria because they're not the ones causing the dental decay. Xylitol is karyostatic. Caries disease process does not occur in the presence of xylitol. This was accomplished in a Belize study from '89 to '93, showing the karyostatic properties of xylitol. The study summary: 40-month double-blind cohort study of 1,135 school children used to determine the impact of sugar-free gums on the decayed, missing, and filled surfaces. The method: randomly assign patients to 9 groups and provide sucrose, sorbitol, xylitol, and xylitol-sorbitol sweetened gums for use. Provide supervision for regular use through school teachers for 200 days with the instructions for use on non-school days, and to evaluate the change in the DMFS at the end of the 40 months. This slide is the same slide that we looked at a few slides back, and you'll notice again that the caries disease process is not taking place. Now, I don't want you to be fooled, and we talked a little bit about this earlier, we don't want you to be fooled with the type of gums that are coming to the market. We have 100% xylitol gum. If you'll notice the ingredients, xylitol, natural gum base, natural artificial flavors, glycerin, gum arabic, soy lecithin, and beeswax. This is the gum that was used in these studies, and we feel that these are the gums that you should be recommending to your patients, not the new ones on the market that have a little bit of xylitol in them and other ingredients that aren't particularly healthy for you. Results suggest that high xylitol content chewing gum usage can retard or arrest rampant dental caries. The BLE study also showed that the pellet versus the stick gum is important in its efficacy. The xylitol group had less than half the cavities of the sorbitol group. The sucrose gum group had the most cavities, even more than the no gum controls. The 100% xylitol pellet or pillow type gum produced the best results with the lowest caries rates, the most remineralization, and the lowest salivary bacterial counts for strep mutans and lactobacillus. The next few slides we're going to show some pictures and results that we obtained in our office with xylitol alone and also in combination with chlorhexidine. On your left side you'll see the normal picture where we've disclosed the child's teeth, and you can see the disclosing solution on teeth. What's important to notice in these slides also is that we didn't ask the parents to brush these teeth any more than they normally do. We also did not clean them the day that these pictures were taken. We just asked them to simply go home, do whatever they normally did, and then come back a week or two later and chew the gum 3 times a day. You'll notice a significant difference on the right-hand side by just chewing the gum for 1 week. In this particular slide is a 4 to 5-year-old child, and you can see that there's a few missing soldiers in the lower teeth, and there's also some wounded soldiers where the disclosing solution is covering them that you really can't see the wounded soldiers until they've chewed the gum. They came back 3 weeks later. You still see the gum tissues have plaque and disclosing solution, but again now we can see the carious lesion on the upper left cuspid that we couldn't see before. This slide shows the importance of actually helping gingival health by the use of xylitol. We're still using 100% xylitol gum in this slide, and this is a child 14, 15 years old in orthodontic treatment. On the left side you can see a puffy gum between the lateral and the cuspid. On the right side, after chewing the gum, the puffiness has been removed. Now, xylitol and chewing gum actually helps other ways during orthodontic treatment in that it keeps the wires flexible, it stimulates the periodontal ligaments so there's less soreness upon movement, and by cleaning the teeth it also reduces the chance for enamel scarring. We're large proponents of chewing gum during orthodontic treatment. The next few slides we're going to use xylitol gum and chlorhexidine. Chlorhexidine, as you can see, does a tremendous job on removing bacteria. Here's another slide again, 2 weeks later, teeth are very clean. Again, lots of disclosing solution on the slide on your left. Xylitol and chlorhexidine after 2 weeks, we still show the teeth are extremely clean at this point. Xylitol gum and chlorhexidine showing again the effects that the two can have on gingival inflammation after only 2 weeks. This 15-year-old girl shows 100% coverage with the disclosing solution. This is a real problem and something that we see in our practice all the time. The significance of this set of slides shows that after 3 months, which normally you would have bacterial regrowth by not using xylitol, shows that the use of xylitol has cleaned those teeth up considerably and puts her in her position to have orthodontics if she so chooses. Xylitol reduces bacterial regrowth after oral disinfection. This slide shows a study that was done having patients rinse with chlorhexidine for the normal 14-day period and then begin chewing xylitol, sorbitol, or placebo gum. What's interesting here is that you'll notice without any other action taken that if we just chew other gums, you have 100% regrowth of bacteria. So from where you started, 3 months later, you're back with the same number of bacteria. Except in the xylitol group, 30% of the bacteria were able to regrow, which will greatly reduce the chance for dental decay.